during the last 10 years. And one of the advances is to characterize breast cancer better using new tools in terms of biology. And the topic I would like to deal with today is just to try to define prognosis regarding the old parameters, the standard parameters, and the new ones. And in the second part, try to review what we have in the literature according to genomics and what could genomics do for us to, one, to have better prognostic definition, second, to try to predict better the efficacy of treatments. I have another solution for you. It's my computer in my bag. If you cannot.
Hello, biology here. Okay, it's easy.
That's great.
You have virus?
No. Thank you very much. Okay, I have no conflict of interest. This is the summary of my presentation, as I just told you. We'll start with the first to define the prognosis of breast cancer following the time of observation, then discuss the tumor biology and prognostic, new prognostic factors, and finally deal with gene profiling and prognosis. The two key questions are presented in this slide is, first, could we distinguish prognosis according to the time of observation at the early period of the follow-up of the patients and at the long term? And the second one is, how could we deal with the new treatments? Because as you know, we moved from mastectomy to conservative surgery, plus radiation therapy. We moved from standard chemotherapy and old chemotherapy, such as CMF, to anthracyclines, and then now to Taxan. And also in terms of hormonotherapy, we moved from tamoxifen to aromatase inhibitors. And we don't know if we have to go back and to do all the trials again with these new treatments. Second one is to deal with the tools, the standard prognostic factors and the new prognostic factors. These curves are, I like this slide because you can show it to your patient. Always the patient question is, doctor, what is my prognosis in the future in the 2, 5, 10 years? What we know from this model is, if you look at here, you can tell these patients that according to all these prognostic factors, we have a risk during the 2 first years, and then this risk is decreasing, and we have another peak here at the 7, 8 years. If you look at here, what you can see that the green one and the blue one here, the tumor size higher than 3 centimeters, and the green one for node positive more than 4, what you can see that here we have the maximum risk of recurrence when you are at 3 years, and also the same thing happened at 7 years here. So if you look at the history, one of the first parameter described in the literature, as you can see it here in 1964, is grade. Histopathologic grade is very important. What you can see here is a series of 250 patients treated between here early at the end of the 19th century. There were advanced breast cancer. 3/4 of them were stage 4, And the median follow-up was at median follow-up of 3 years. What you can see here is that the survival, the median survival, of course, decreased. However, most importantly, what you can see here that at 5 years, all the patients who were grade 3 died from their cancer. This is usually what we do in multidisciplinary approach. You can distinguish here the boss, who is asking us to do the best treatment. And we are here discussing about the patients and the prognostic, what are the best factors to take into account to define our strategy. Mainly, either considering total mastectomy or conservative surgery. You note here that we have the same parameters very widely reported in the literature. Age, of course, tumor size, node, grade, length of vascular invasion, and multifocality. According to these parameters, of course, we will give treatment to our patients, either local regional treatment, but also systemic treatment. And now we are going to move on and to try to find, can we, with the new parameters, find a new classification of these prognostic factors. But just before that, let's go back in 2 slides to what we know from the meta-analysis published earlier. What you can see here, when you give, for example, radiation therapy after conservative surgery, here, the impact of radiation therapy on local recurrence here, either considering node negative or node positive, you have a gain here of 5 years, 16%, and this gain is higher, it is 30% at 5 years when you have node positive patients. So clearly, early at 5 years, as we have been discussing, if you don't give the right treatment to your patients earlier, you will have recurrence and you will decrease your local control. But if you do the good job, you give treatment, a complete treatment, including local regional radiation after conservative surgery, you will impact the survival at 15 years. You can see it here from the meta-analysis. Remember, we had a gain in terms of local control earlier, and we impact here survival. At 15 years, we have a gain of 5% of survival in these patients who are node negative, and we gain here 7% in the patients who are node positive. This is very important to just to summarize you the importance of early and late prognosis of for the patients. So, as I told you earlier, of course, this meta-analysis has been done with all data, all treatment, and you all know here that we moved here from surgery, we did during half of century radical mastectomy and axillary dissection. We moved to conservative surgery with sentinel node biopsy. In terms of radiation therapy, of course, we also moved from old techniques to new technology, and we will discuss this afternoon the new concept or new approaches like accelerated partial breast irradiation. And also we are moving now to IMRT and also gating and using new technologies. For systemic treatment, we moved from tamoxifen to aromatase inhibitors. We have taxane, and now, of course, for HER2 patients, we clearly demonstrated that there is a benefit, a 50% benefit to give Herceptin for HER2 positive patients. So all these items should have to be considered regarding what we know from the old studies and also from the meta-analysis. What's about biology? In terms of biology, if you want to just to focus here on the subtypes, You look here in the first point is luminal A tumors, which are hormone receptor positive, HER2 negative. Luminal B are mainly hormone receptor positive, HER2 positive. HER2 tumors are hormone receptor negative, HER2 positive, and triple negative patients that do not express hormone receptor and HER2. From this study, it's a retrospective study from the Boston group. Patients treated between 1998 to 2001. You see here the number of patients, almost 800. Age higher than 55 in half of them. No trastuzumab in this series, of course, it's an old series. And there were patients who had good surgery. Good surgery means there is no remaining tumor in the tumor bed. 97% of the patients had margin negative. And what you can see here, we have a very good results at 5 years with only 2% of local recurrence. But when you look at 5 years, there was a difference between luminal A, luminal B, when you compare them to HER2 and triple negative. You have 8%, 7%, and only 1 to 2% here. This means probably something is happening here, and probably have more aggressive tumors with HER2 and triple negative tumors. This was also significant in multivariate analysis. When you consider luminal A as a reference, you can see here that HER2 and triple negative tumors were independent factors in terms of prognostic. There is another more recent 2010 more recent publication also with a higher number of patients, almost 3,000 patients, follow-up 12 years. What you can see here again, for triple negative, there are mostly very early recurrences. And here, if you look at again in the multivariate analysis with this very high number of patients, you see that HER2 and basal-like patients have impact independently the prognosis of these patients. So what's about HER2? Let's focus in 2 or 3 slides on HER2. What you can see here is very small tumors. This is a GNSU series from Finland, published in 2003. 6 to 10 millimeters, grade 2, 3, and they looked at the difference between expression or not expression of HER2, and you can see here the difference in terms of distant disease-free survival, but also in distant disease, in distant metastatic disease. There are the patients who expressed HER2, even they have small tumors, did worse than patients who do not express HER2. This is also seen here if you look at the patients who are only node negative, which are supposed to be better. The expression of or amplification of HER2 can produce a difference here, again, in terms of survival. And if you take again small tumors, less than 1 centimeter, HER2 is a discriminating factor in terms of prognosis. In this is summarizing what I told you earlier. Even you have standard prognostic factors which are somehow reassuring the patient. If you look at HER2, only HER2, you discriminate two populations. Just to show that finally what we can conclude from these studies is that amplification of HER2 is an independent and favorable prognostic factors either considering node-negative or very small tumors. There is another publication that have looked at the distant metastatic risk when considering hormone receptor HER2 after in patients who had mastectomy, total mastectomy and radiation therapy. There is here the results of this study. Here you have hormone receptor positive. Here you have HER2 positive patients, and here you have triple negative patients. The idea was to have a look between patients who received radiation and those who did not receive. What you can see here is in triple negative, for example, there was no difference. However, when you look at the local regional control, patients who received radiation therapy did better in triple negative, and this is overall survival. When you look at here again for HER2 patients, you see here there was a trend, but the difference was not significant between no radiation therapy and radiation therapy. Many other parameters could be taken into account. However, we are not using them in routine today. For example, BCL2, in 500 patients, there was a correlation between hormone receptor positive and a local relax. And what you can see here, BCL2 patients negative and BCL2 positive patients with a difference in terms of survival. You can here find in multivariate analysis again the impact of BCL2. So we have some other parameters which are coming in the literature. Now let's move to the gene profile. Of course, we also have these tools, but not everywhere. We don't do them, of course, routinely today. I think that they are a real perspective for the future. And for example, is it possible to define here a particular risk in the population? When you look at here, this is a very good example. You have liminal A. You remember the risk of relapse in these patients, 1%. Here what they did is to look in this series, what is the impact of gene expression profile? They demonstrate that when you take only liminal A patients, here AT patients, compared to the basal patients, 58, you can see here then in liminal A, you can discriminate using gene profile two subgroups. One is liminal AA, the second one is liminal AB, and what you can see here is the liminal AB is close to the basal here. So in one subgroup, which is considered as a very good prognosis, you can see here that with the gene profile, they could discriminate two subgroups. One is really good prognosis, but the other one probably not. This is another study, 143 patients, very good prognosis, node negative, margin negative. Here you have 20 patients who had local recurrence after radiation therapy. Here you have 80 patients who had no local recurrence and no radiation therapy. The conclusion of this study was that the gene expression profile can provide added value to the conventional markers to discriminate and to predict local recurrence. You can see them here. You have all the patients here, and you have the 20 patients just here with the red area here, which is related to these 20 patients who received radiation therapy but presented local recurrence. So gene expression profile could define here this population with high risk even they receive the right treatment. Another example from Korea, I think, with the 43 genes that are mainly involved for revealing proliferation, cell death, cell cycle, DNA replication, and repair, human response. You all know also that we have the discussion for 1 to 3 node positive patients. Should we give radiation therapy or not? There is a trial, I don't know what's about that trial now, Supremo, an URTC trial comparing in this subpopulation 1 to 3 node positive radiation versus no radiation. What they did for this in this work, they looked at this subgroup, and they could discriminate using this model, a predictive index by these 34 genes. They showed that this index could discriminate the patients who would benefit from radiation therapy and those who will not. So it is a new tool, probably when we have a key question in a subpopulation regarding treatment or not, maybe this kind of approach will help to discriminate the population who would really benefit from our treatments, and particularly from radiation in this study. I go a little bit fast now. There is another study that concluded with this supervised analysis that the gene profiles also can predict the local recurrence even you have very few events. Remember the paper with 20 patients, very few events, and you can predict with the signature, which is an independent factor. So, in another hand, what we have also in the literature some examples who did not find any difference using gene expression profile. This is an example from Craig here, who looked at the set of genes, and he studied all the set of genes that could help to discriminate the population. There is no one could discriminate here local recurrence. However, gene expression profile could help here to clearly demonstrate the correlation between the primary tumor and the recurrence, and it could help to clearly and definitely prove that the recurrence in the breast is the primary tumor and not a new cancer. Finally, in conclusion, what we can say for prediction with gene profiles is that current studies results are still controversial. We have some positive and some negative studies, and we have probably to encourage further investigations. This is my conclusion. First of all, in terms of prognosis in breast cancer, local regional control impact clearly long-term survival. So we have, I think, the key message here is when you do conservative surgery, we have to give radiation therapy and standard radiation therapy today, 6 weeks of radiation therapy. And the decision making today in the routinely use, of course, the standard parameters are very important to take into account in a multidisciplinary approach with the surgeon, radiation oncologist, pathologist, radiologist, together to discuss the patient and the cases before taking our decision. And new tools such as gene profile are probably very interesting, but they are not routinely used today for at least discriminating the patients who should or not receive radiation therapy. In terms of tumor biology, of course, new classifications are very interesting. we see in the literature that even we consider small tumors, when we have HER2 positive patients, we have to think that we have to give Herceptin and probably chemotherapy. For example, in the St. Gallen recommendation, you know that we are at 6 millimeters, which means that if you have a tumor with 6 millimeters, HER2 positive, and you are sure that it's the invasive component and not in situ component, you have to give chemotherapy at least 4 cycles and plus Herceptin for 1 year. And the tailoring strategy with tumor biology is, of course, not just a dream. I think that we will move on and we will have the opportunities to discuss this in the future, in the near future. Gene profiles are, for the moment, under investigation. I think that we have to encourage all the studies, and particularly the multi-center studies, to define or to help to define the best treatment to the best patient. And finally, I would like to thank you for listening this talk. Yeah, you. And I invite you, as Professor Kutan and Zwiebenstein suggest, if you have students, our home has a very nice course in Istanbul every year. We will do the 3rd one this year. And until now, we were dealing with radiobiology. And after this year, we will deal with also basic biology. And if you have students, and I will really be happy to have them with us in Istanbul. Thank you.